When I learned this work, I learned evidence doesn't matter. What matters is patient satisfaction and outcomes. And while that does matter, I think we need to do better than that. As I started putting all of this work into more academic framework, this is a technique that I struggled with because I could never find a study that talked about a reason for why we'd even consider treating here. And then I came upon an old paper by a speech pathologist by the name of Morrison. Morrison wrote a paper in 1997, it's referenced in your manual, called Muscle Misuse Disorder, or Pattern Recognition in Muscle Misuse Disorder. What do we do? And it was basic. You know what pattern recognition is? It's something you and I use constantly throughout a day. We are walking down the sidewalk, we want to cross the street, but you hear a car coming. We recognize a pattern from the past. It's not safe to walk out, so we don't. We look first, right? It's a simple recognition of pattern recognition. Morrison was talking about in various aspects of muscle tension dysphonia, if a patient displays this characteristic, you may want to check this area or do this test. That's sort of a framework to look at taking evaluation into intervention. And when he talked about certain, he was calling it muscle misuse disorder, which is another older term for muscle tension dysphonia. He talked about with too much muscle tension between the larynx and the spine, you get diminished laryngeal excursion up and down. Good so far? And he described specifically the inferior constrictor muscles, which basically connect the back of the larynx to the front of the spine. And when the muscles contract, they constrict the larynx back against the spine. It was his rather simpler contention that too much tension in the inferior constrictors pulling the larynx back reduce laryngeal excursion, which reduces our ability to change pitch, for instance. Okay? And as a result, causing that muscle misuse disorder. So what he was advocating for was to reduce that muscle tension. He was working from the framework of laryngeal manipulation, that if we do provide that movement, it breaks the tension and allows the larynx to rise and fall easier. But the cool thing to me was he talked about this space. He called this the laryngeal gutter. If you could look at it in this direction, you know the gutter on your house or on the side of the road, right? It's sort of a trough. And he talked about that space right there being the laryngeal gutter, where the muscles that connect those two, if they're too tight, just basically block that off. So he's talking about freeing up the muscle tension in the laryngeal gutter.
You know, it's been a while since I recorded that video and continue to reflect on Morrison's paper, Morrison's intentions in terms of accessing that perilaryngeal, that retrolaryngeal space. And, you know, I'm struck with how we, as clinicians, you know, in an attempt to follow the evidence, we get so narrowly focused on what an individual says about what must be done, and that's how they did it in a study, that we maybe lose track of that's one idea of what can be done. And I see problems like this with protocols, that people who feel the protocol must be obeyed completely, or we're failing an evidence-based perspective, or in Morrison's case here, that the only way to break that laryngeal tension in the laryngeal gutter is to do aggressive manipulation. Now, I have learned that over the past year that, yeah, more aggressive laryngeal manipulation is often helpful, but gradations of it are often really helpful for individuals. I, as an individual, as a human being, don't like when somebody grabs my larynx and really wrangles it from side to side. That's been proven to me on a couple occasions when during classes, lectures, etc., where we're practicing that, and my nervous system just doesn't respond to that sort of input. And I often wonder, what about the rest of the people you and I see who we might be touching? Whether it's aggressively or manipulating the larynx or pulling the tongue with a lot of force, are there ways to grade all of these interventions, whether it's the concept of Morrison's intervention or other ones, to the point where we're following the spirit of the evidence, but we're also following the spirit of the human being that we're working with, realizing that, you know, one size doesn't fit all. Some people almost need a lighter touch or a more aggressive touch in order to hit some of those centers of the brain that says, yeah, I think that's going to be relevant because you're using something that feels useful to me. So when I take a look at these studies, I certainly learn a lot from them. Yeah, I find support for the work that I use and teach, but I also see them as a general guideline, not this very explicit set of rules that I have to follow. So hopefully that helps you understand why we might want to explore the posterior aspect of the larynx through various sorts of manual therapy, reduce that laryngeal holding. Thanks for watching.